Alteration in Neurological Function, Part 2. Upper motor neuron syndrome causes a spastic paresis, which is weakness, or paralysis. It rarely affects the face. Spinal shock is cessation of spinal cord function below the level of injury. It causes a flaccid paralysis, no reflexes, and a disturbance of bowel and bladder, so they don't function properly. This lasts days to weeks. This is the reason that when somebody has spinal cord injury, they cannot tell how much damage there has been until this disappears. There's a table on page 355 that you need to look at. Now, the spinal cord shock is usually due to the edema that occurs at the site of the injury, putting pressure on that spinal column. And it's only until that edema resolves that they continue to have the weakness or the paralysis. Huntington disease, or Huntington chorea, is an autosomal dominant degenerative disease that we discussed under the genetic topics. Just to remind you, it's a depletion of your neurotransmitter GABA from the basal ganglia. Both your motor and mental function are impaired, but it doesn't start until you're in your 40s. Age of onset is 30 to 50. You need enough dopamine, and in this you have too much dopamine. So you end up with hyperkinesia, dementia, anxiety, depression, and these fragmentary movements, these choreiform movements that they have, like an abnormal dance. Lower motor neuron syndromes are a dysfunction of both the voluntary and involuntary movement and decreased muscle tone. You're going to have hyporeflexia, so that you're going to have your reflexes, but they're not going to be as strong as usual. You may also have areflexia, which is the loss of the reflexes, and you will have flaccid paralysis. After several weeks to months, atrophy will occur. Amyotrophy originates in the anterior horn cells or the cranial nerves, and an example of this is polio. And we do have a vaccine against polio, so it's due to a virus. Nuclear palsy is the brainstem syndrome that involves the cranial nerves, and an example of this is Guillain-Barré, which we'll talk about in just a minute. Akinesia is a decreased voluntary and associated movements due to a decrease in dopamine or dopamine receptors, and that's Parkinson's, and we'll talk about that also. And bradykinesia means you have slow voluntary movement. Guillain-Barré is a progressive muscle weakness and paralysis. It is reversible. It starts at the toes and works its way up, and it can go all the way up to involve the total body, or it can stop part way. Nobody knows what does that. It is reversible over time and tends to have no permanent damage, depending upon how long the paralysis or the weakness lasts. It can progress to the point that it involves your diaphragm and can cause a respiratory arrest, but it rarely causes permanent damage. They think it's due to a virus, the Campylobacter jejuni, but it starts at the toes and works its way up, and then when it recovers, it does it in reverse or descending order. So it starts where it stopped and went down. I took care of a young man where the Guillain-Barré progressed to the point where he could not even blink his eyes. The only way he knew what was going on is we had him on an EEG monitor, and we talked to him. His brain waves would change. He was on a ventilator, of course, because he couldn't breathe. And he was on the vent for about 3 weeks, and then it gradually started to decrease and go back down the other way. He went to physical therapy, and I think it took him about a year, but he ended up with no permanent damage, but it took quite a while. And this is from the memory book showing the Guillain-Barré. They think it could be autoimmune. They have associated it with some immunizations that have been given, but usually it's due to, they think, a virus. Tends to increase in, another increase has been noted in following delivery of a baby. So it just kind of makes they don't really know for sure. They can't put one point on it. This also talks about ways to treat. Alterations in your complex motor performance. This is your posture, because posture takes into account balance and equilibrium. Dystonia is maintenance of an abnormal posture through muscle contractions. Decorticate is where your brainstem and your cerebral cortex are not talking. This is an upper motor neuron problem, and you'll have extension of the feet and the hands that they turn out. I'll show you a picture in just a second. Decerebrate is where all four extremities are extended. So decorticate, they come back to the hands come up to the core, the inner part of the chest, and decerebrate, they go out. You can have somebody who has decerebrate activity on one side and decorticate on the other. And this is from the memory book showing the different types of posturing. This decorticate is a problem with your cervical spinal tract or the cerebral hemisphere, and decerebrate is a problem with your midbrain or your pons. And you can see they're more extensor with decerebrate. This again is another picture showing your abnormal posturing, and it's showing decorticate, then decerebrate, and then somebody who's flaccid. This is from another textbook that we had showing again decorticate rigidity and the decerebrate rigidity that occurs. Decerebrate is more ominous than decorticate. It indicates lesions in the brainstem at the midbrain or upper pons, and that means it's difficult for them to maintain respirations on their own and possibly even their heart rate on their own. You've got flaccid down in the lower left, and you've got apisthosnos on the lower right, and this is prolonged arching of the back with the head and heels bent backward, and this is usually with meningitis. And this is a table, I apologize for the quality of it, that talks about abnormal reflexes. Your Babinski, how you test it, what it shows, Oppenheim, Gordon, Hoffman, Koenig, and Brudzinski. Those are just different reflexes that you need to know about. Parkinson's disease is a degenerative disease of your basal ganglia. In this, your dopamine secretion fails, so you don't have enough dopamine. So you end up with an imbalance between your dopamine and your acetylcholine activity, your dopaminergic and your cholinergic activity, so the sympathetic and parasympathetic. They have to stay in balance so that you can stay in balance. When they're not in balance, acetylcholine takes over, and that's more of an excitatory stimulus, and so you end up with a resting tremor, so your hand shakes when you're at rest, and in rigidity, it's difficult to walk, and difficult swallowing. Ataxia is an abnormal gait, trouble walking. There's no way they could walk a tightrope like this guy here. And you'll have akinesia and pill rolling. Pill rolling is like at rest if you take a pill and put it between your fingers and roll with your thumb. But that stops when you go to do something. It tends to have an insidious onset, so it's a rather slow onset. And you don't usually notice it until after the age of 40. But over time, this is over the age of 50, over time you get a mask-like blank expression. You move a whole lot slower. It's a lot more difficult for you to get things started. You have a stooped posture. You can have some mental deterioration and depression because you're not doing what you used to do. You tend to shuffle. Tends to occur more in whites, rarely in the blacks. You all know Michael J. Fox, a comedian who developed Parkinson's at the age of 21. That is quite unusual. The usual age is in their late 40s, early 50s, and later. There are a lot of different treatments, and you'll learn about that in 224. With your gait, there's some different types of gaits that you might have. An upper motor neuron dysfunctional gait is one in which you have foot drop whenever you get tired. Spastic gait is where you have a unilateral injury. The leg is extended and stiff. If any of you have watched the old Gunsmoke shows, really old, the first ones that had Dennis Weaver playing Chester. He would walk down the street with a stiff leg and would not bend that leg at all. That was a spastic gait. A scissors gait is where you have bilateral injury with spasticity, and so you walk in kind of a scissors fashion. Cerebellar or ataxic is where your center of gravity is wide-based. You got your legs far apart. You keep your pelvis stiff, and then you tend to stagger when you walk. Basal ganglion, again, is another broad-based gait, but you take very small steps. And senile or pseudo-Parkinsonian, it's when you have a frontal lobe dysfunction, and you also have a broad-based gait. There's some motor aspects involved with expression. Hypermimesis is a pathologic laugh or cry. This means that you have damage to your left hemisphere. If you cry, if you laugh, it's to the right hemisphere. Hypomimesis is loss of your emotional language. You tend to not express verbally anger or joy. Dyspraxia is the inability to perform purposeful or skilled motor acts. And aprosody is the absence of variations in your pitch, your rhythm, and your stress in speech, so that there's absolutely no change in inflection. There's no indication that anything that they're reading may mean anything to them, or anything they're talking about may mean anything to them. There was an actress back in the 1940s who made a whole career of talking that way. Extrapyramidal motor syndromes are, for example, your basal ganglia motor syndromes. These will alter your muscle tone and your posture. Your cerebellar motor syndrome will decrease muscle tone and cause a problem with your coordination, your equilibrium, and your gait. Central nervous system disorders, you could have a traumatic brain injury. And that traumatic brain injury would cause a concussion, which is a minimal loss of consciousness, or a cerebral contusion, which is loss of consciousness with amnesia and confusion, a little bit more severe. There are different types. You've got your closed or blunt trauma, where the dura remains intact and the brain tissue is not exposed. Then you have an open or penetrating trauma that causes exposure of your cranial contents to the environment. A focal brain injury is where you have a grossly observable lesion. A subdural hematoma will increase your intracranial pressure and cause herniation if it's not treated of the brain. An intracerebral hematoma also will cause an increase in intracranial pressure with edema formation. And an epidural hematoma is usually due to an arterial bleed. It is a surgical emergency because it can actually cause the temporal lobe to shift and or herniate. Trauma can cause different types of injury. A coup injury means that you have damage at the site of the injury. A contra coup injury, because the brain sits on your spinal column in a bath of cerebrospinal fluid, it kind of floats in your skull. So if you hit the brain on one side, the skull on one side, the brain will hit the other side, the opposite side of the skull, and will cause what's called a contra coup injury. It's an injury at the opposite side of the injury. It can cause, either one can cause cerebral edema, which if it isn't controlled will cause permanent brain damage or brain herniation and brain death. It tends to peak within 18 to 36 hours after the injury. It also causes damage to the neural tissue, to your brain tissue, and will increase intracranial pressure. And remember, that's only 5 to 15 to start with. So here's a picture showing a coup injury to the frontal and a contra coup to the occipital, and how the vessels can be torn in there. This is not from our textbook, so don't look for the picture on page 802. A contusion is the most common type of injury that occurs in the frontal lobe. It results in changes in your attention, your memory, your affect, your emotion, your executive function, which if you remember is your ability to add two and two and come up with an answer, among other things, and your behavior. It can be superficial. Symptoms are a loss of consciousness. You'll have brief periods of bradycardia and loss of your reflexes. That loss of consciousness should be less than 5 minutes. The bradycardia will cause a drop in your blood pressure, but your vital signs should return to normal within a very few seconds. If it becomes hemorrhagic, it will result in an intracranial hematoma. I'm going to go back for just a second to our contra coup injury. If any of you like old television shows, Perry Mason. Perry Mason was an attorney who was played by Raymond Burr on television back in the late 50s, early 60s, when I was just a little tiny baby. But anyway, periodically he would have the court or the pathologist decide whether or not the death of the individual was due to the coup or the contra coup injury. What difference it made, I never really understood, but he seemed to make a big point of that. The point I want to make about a coup injury, a contra coup injury, is that the contra coup injury doesn't show up immediately. It usually takes about 10 to 12 hours to show up unless it's a really severe injury that causes that. My dad fell off of a ladder onto a cement floor, hitting it with his head when he was changing a garage door opener. Life flighted to St. Vincent's. He was found to have a subdural hematoma where they did burr holes and removed the hematoma. And he was in ICU and did very well for 12 hours. And then the contra coup injury started to take over. And his ICP climbed drastically. They told us at that time they could go back in and evacuate it, but by trying to get to the contra coup injury, they would remove everything that made my dad special. And thankfully he and Mom had talked, so that was decided not to do. But it was the contra coup injury, the later bleed, that killed my dad. Not the original trauma, but the later trauma. Of course, the later trauma wouldn't have occurred if he hadn't had the primary trauma. But you may hear them talk about contra coup injuries on murder mystery stories. Okay. Anytime you have a head injury, in the first 24 hours, you're going to have a change in your level of consciousness. It's going to indicate that you have an increase in intracranial pressure. Remember, it doesn't mean coma initially. This is showing increase in drowsiness, confusion, difficulty to arouse. That's why when somebody has a head injury, you wake them up every couple hours and check their pupils and ask them if they know where they are and make sure they make sense and don't have any slurred speech. Again, this is from the memory book. An extradural hematoma, epidural hematoma, or hemorrhage is the most common cause. The most common cause is arterial bleed. And this is a surgical emergency because arteries bleed fast. Symptoms are change in your level of consciousness or loss of consciousness. Then you wake up and you're lucid. That means you make perfect sense for several hours, even a couple days. And then you get a severe headache, vomiting, drowsiness to seizures. And if they develop an ipsilateral pupillary dilatation, means that the patient's herniating and there's poor prognosis. Now, ipsilateral means it's on the same side. Ipsa means same. So on the same side as the trauma that occurred. They have a very poor prognosis. A subdural hematoma can be acute or chronic. If it's acute, it can progress rapidly over several hours. That causes a decrease in your level of consciousness and then symptoms of increased intracranial pressure. chronic tends to develop over weeks to months. It tends to occur mainly in the elderly who fall, and in alcoholics who fall. Symptoms are chronic headaches, tenderness over the site of the hematoma, increasing headaches, nausea, vomiting, increased confusion or agitation, and progressive dementia. Hematoma, this is showing an epidural here, subdural here, intracerebral there. An intracerebral hematoma usually occurs in the frontal and the temporal lobe. The small vessels are damaged by the shearing forces of the brain going back and forth, and the hematoma acts as an expanding mass. Symptoms are an increase in intracranial pressure, contralateral hemiplegia, so on the opposite side you're going to have weakness, a positive Babinski, and temporal lobe herniation. Diffuse brain injury is also called diffuse axonal injury, or a shaken baby, because it's a shaking effect on the brain. It produces strains and distortions within the brain close to the brainstem. It takes 12 hours to several days for damage to actually show. Symptoms are dysphagia, dysarthria, disorientation, confusion, attention and memory deficits, learning and judgment difficulties, agitation, and depression. Spinal cord trauma results from the acceleration-deceleration injuries. The bones, ligaments, joints of the spinal cord can be injured by a fracture, a compression, or a dislocation. They're classified as a simple fracture, which usually affects the transverse or spinous process of the spinal column, a compressed or wedge fracture, which affects the body of the vertebrae. It's usually compressed anteriorly, comminuted or burst fracture, where the spinal column, the bony surface, is shattered, or a dislocation, where the supporting structures are torn. Now, if the spine is flexed at the time of the injury, the vertebrae move forward and become angulated. And this is showing a spinal cord injury. Above C4, you have paralysis of your respiratory muscles and all four quadrants, so you end up quadriplegic. The higher the injury, the greater the loss of function. And so, the guy diving into the bottom left is showing axial loading, where you can snap that spinal column. Here showing a compression fracture. It's nicely circled. When the vertebral column is injured, microscopic hemorrhages occur, leading to necrosis of the gray matter. Edema develops, causing impaired circulation to the spinal cord. C1 to C2, you'll have a respiratory arrest. C3 to C5, your phrenic nerve exits through there, so you'll have diaphragmatic breathing that's impaired. You end up being a quadriplegic. Damage between T12 and L2, you'll be paraplegic. Your symptoms depend upon the level of the injury and are due to a lack of nervous discharge from the brain and the brain stem. Do any of you remember Christopher Reeve? Christopher Reeve was show jumping a horse, probably 25 years ago. Anyway, after the Superman films. And the horse refused to go over. He went over and landed on his head. If there had not been somebody there who knew CPR, he would have died. They knew CPR. He ended up on a vent for the rest of his life. The nice thing, it's not nice if somebody has a spinal cord injury. But until Christopher Reeve had his spinal cord injury, all the treatment for somebody who did have spinal cord trauma was designed to help them live with it, to show them ways in which they could cope. After Christopher Reeve, research began on how to reverse the effects. We're now using stem cells, or looking at stem cells, so looking at TENS units that kind of stimulate below the level. There's all sorts of different things that are going on now, and it is totally thanks to Christopher Reeve and his friends who pushed to try and make it possible for him to be able to walk again. This ends part 2. We'll start part 3 shortly.